Hey everybody, Dr. Patel here. Sorry about the delay. Here today talking about a couple different things. We're wrapping up our series of talks on looking at the lumbar MRI or the MRI of the low back. And this is part 3, and we're just going to talk about 2 little subtle things that your radiologist might not actually mention on the report, but could actually be a strong hint as to what's going on in your low back. So if this is the first time that you're tuning in, then please look at our prior videos. You can find them on our Facebook page. You can find all of our videos from the past on our website, fxregencenter.com, or on our YouTube page. Just look for the Patel Center for Functional Regeneration. But today we're going to be talking about some subtle things. Now, some of these things might not always be so subtle, but it's something that's important that I think is oftentimes overlooked because it's not necessarily something that a radiologist is going to mention because it's not necessarily something that's surgical. It's not something that's necessarily severe, but can be a hint as to what's going on mechanically, and can actually be a direct hint to your pain as well. So, first I'm going to take a look at this MRI, and I'm going to review a little bit of the anatomy and focus specifically on this little thing that sometimes is very, very obvious and sometimes is commented on, but oftentimes is not. So when we look at this view here, this is looking at a side view of this patient's spine. This is the front of the body, this is the back of the body, this is the top, this is the bottom, right? And when we look here, these squares are the vertebral bodies, the bones. These are the discs in between, right? This is the central canal here, where all of these yellow lines that we see here are the nerves that are going to be exiting on either side. Okay. We don't see them exiting right now because this is a cut right in the middle of our spine. It's a cross section right in the middle of our spine. So we don't see the holes where the nerves are exiting on either side. Now, when we look over here, these things that we see back here are your spinous processes. These are our kind of the nubbins that we feel when we press the back of our spine, right? And in between these spinous processes are these things called the ligaments. On top of these spinous processes are the supraspinous ligaments. In between are the interspinous ligaments, right? And these ligaments are actually continuous with this fascia or soft tissue that covers our superficial low back in this region. And that actually wraps around all the way up and is connected with our muscles of our abdomen, our transverse abdominal muscles, our obliques, and our rectus abdominis in the front, all the way to the linea alba, the thin tissue in between our six-pack muscles. All of that is connected with fascial tissue all the way to the back here, and this is called the thoracodorsal fascia that wraps around. Now, I'm taking a second there to talk about this, and we'll look at it from a different view in a second here as well. But I'm taking a second to talk about this because that thoracodorsal fascia that's very superficial is continuous with the supraspinous ligament, is continuous with the interspinous ligaments, right? And that's continuous with these deeper ligaments that are over here called your ligamentum flavum. And this ligamentum flavum is this thick ligament that borders the back of the spinal canal. This ligamentum flavum is this thick ligament that borders the back of the spinal canal. Okay? Super important ligament that I'm going to go into a little bit more in depth with, okay? But when you look at it without the drawings in place, you can see that this ligament is a nice black straight line in some areas, but in some areas it's actually kind of kinking or folding in on itself. Some say the word that the ligamentum flavum is actually thickened, but in actuality you can imagine that it's kind of kinked down on itself, and that's why we get this thickened appearance there, right? It's kinked down on itself, and that's why we get this thickened appearance there. This is really important. Now, before I go into why that's important, what are ligaments? We've gone over this before. The ligaments are the duct tape that connects bone to bone, or as you've heard me say before, they're like those really thick rubber bands that surround broccoli in the grocery store, right? So they're strong, they're supportive, but there's a little bit of a stretch to them. And those ligaments essentially are supportive structures. They're what connects bone to bone, and that's what provides stability to the whole spine and to all of the bones in our body, right? Now, if we take that a step further, as we're getting older in general, or even when we're young and we have conditions like hypermobility, those ligaments can slowly get stretched in different ways. For somebody that has hypermobility, that's somebody that's double jointed or super loosey-goosey type of bodies. Those ligaments, those rubber bands throughout their bodies are generally a little bit more stretched, generally. But as we get older, when we talk about the spine, we've talked about this before, as these discs, as our discs here start to lose fluid, and instead of being nice and cushiony, they start to get a little bit more wobbly, and before even they get to the point that the height of the discs have actually decreased, right? The water balloon that the disc is starts to get a little bit more wobbly, and there's a little bit more motion that takes place. As there's motion that's taking place over years, you can imagine those thick rubber bands start to get gradually stretched over time. So these ligamentum flavums start to get stretched, and then as the vertebral bodies move forward comparison to the other, right? This one is forward in comparison to this one. You can see that kind of step off. We've talked about that spondylolisthesis thing in prior videos. But as that vertebral body pulls forward a little bit, this ligamentum flavum is going to start to get stretched. Similarly, as the height of these discs start to decrease, again, the height's going to decrease and the ligamentum flavum is going to kink down on itself, and what is seen as kind of thickening. Now, a lot of folks say that ligamentum flavum thickening or kinking, once it starts getting more severe, you can imagine how that's going to start to narrow your central canal, particularly when you also have disc bulges here or you have arthritis going on. This central canal can start to get narrowed, right? That can cause spinal stenosis. And it's not until, this is significantly happening that radiologists are usually saying, hey, there's multifactorial spinal stenosis going on, right? Such as right here, where all these nerves, as they're traveling in this area, they're really getting pinched by this ligamentum flavum on one side, disc on the other. But when this ligamentum flavum hypertrophy or kinking or looseness is actually a little bit more subtle, right? When that's something that's going on that is not necessarily causing central stenosis, like in these two areas down here, right? Those two areas are not causing narrowing of where these nerves are traveling. There's plenty of room here, right? There's plenty of room here. But that could be a sign of some micro instability in that area. That could be a sign of the way that other things can get irritated, right? That's not necessarily the pain generator. that's not necessarily the thing that's causing you to have pain, but that little bit of motion or instability or looseness of those ligaments can then contribute to things like tears inside the disc. It could then contribute to rubbing of the facet joints and causing pain in those joints in the spine. Various different things can occur when you start to get some looseness of these various ligaments. So, you know, it might be something that your radiologist mentions as words like ligamentum flavum hypertrophy or ligamentum flavum redundancy. These are the type of words that you'll see in your report. It may or may not be there, though, if that hypertrophy or kinking of the ligament is actually very, very small. But it's something that if you're going to a physician for treatment, particularly if you're getting regenerative medicine treatments, that could really be beneficial for not only the pain generator, but all the functional components, all the mechanical components of the spine, then it's really important that that physician looks at your MRIs. We cannot go by just the report because there's a lot of things that we could be missing. When I see patients that have these signs of instability, it's not just important to treat the facet joint that's angry or painful, or the nerves that are irritated in the epidural space. It's equally, and perhaps even more important, long-term, to also use your body's own biologics injected directly in the area of ligament loosening, such as that ligamentum flavum. And there are techniques that we can do that I teach with organizations like the Interventional Orthobiologics Foundation, that we can actually go and use a needle and inject directly into the ligamentum flavum, as well as directly into the interspinous ligaments, the supraspinous ligaments, and the thoracodorsal fascia. And by injecting at all of those parts, that continuum, we can strengthen all of those things and actually take some pressure off of the ligamentum flavum, and therefore provide more stability and take some pressure off of nerves. And when I first started doing this, I was like, all right, this is great in theory, but am I actually seeing any of this occur? And we have actually seen some cases at this juncture of ligamentum flavum hypertrophy or kinking actually decrease a little bit. It doesn't always happen, but even if you can get that to decrease in terms of millimeters, that can take some pressure off of nerves where there is significant stenosis, or provide some stability in areas where there is not. And I'm going to show you kind of an example of what a cross-section looks like here, and what ligamentum flavum, interspinous ligament, supraspinous ligament, what all that stuff looks like right now. So let's see here. I'm just going to zoom in a little bit for you. Now this is a cross-section of the spine. And this is the front of the body. This is actually as if you're lying down on your back right here, and your head is past the screen, your feet are towards you. So this is the front of the body, this is the back of the body, this is the right side of your body, this is the left side of your body. When we look over here, these are actually the kidneys right here, right? These are your blood vessels. This is your vertebral body, or the bone. These are your facet joints. This is your central canal, where the white is the cerebrospinal fluid, and all of these yellow dots are the nerves that are exiting on either side over here. And over here we have your paraspinal muscles, okay? And particularly the multifidi, which are these small little muscles on either side. We're going to get into those details in just a minute. But what I want to point out over here is that this right here, this thickening, is the ligamentum flavum on both sides, okay? So that, oh shoot, sorry about that. That thickening right there on either side, that black, is the ligamentum flavum on both sides. And you can see how that is actually continuous with the interspinous ligament, which is between the spinous process, continuous with the supraspinous ligament and continuous with the thoracodorsal fascia that goes on either side and then wraps all the way around to the stomach and is involved with the core muscles. Okay. Now, when we look at this, we can see how, yes, of course, if this ligamentum flavum over here is significantly kinked and thickened, then that can be narrowing the space where the nerves are traveling. But even if that's not, then these are integral parts of the stability of the spine. So that can be a sign of some micro instability that can be contributing to other things that are your pain generators, so to speak. So what we do in our clinic and others that we teach, we inject directly into the ligamentum flavum, directly into the interspinous ligaments, the supraspinous ligaments, and along the thoracodorsal fascia in order to try to tighten all those things with your own blood growth factors called PRP, with sugar water injections called prolotherapy. And in rare situations, if there's a specific defect or tear in these structures, we can actually use other things like bone marrow cells to actually try to heal some of those tissues as well. But I actually want to, go back and show you this image again because I want to focus on the next thing that radiologists often do not comment on, but I think is super important as a hint to what may be causing your symptoms or your pain. So I oftentimes see patients that actually have relatively normal looking MRIs, right? They don't have major disc bulges. They don't have like a disc herniation pressing on a nerve. They might have a little bit of arthritis, but we don't necessarily feel pain coming from those joints when I examine them. And they may present to me with, pain, numbness, tingling going down a leg, but they have zero evidence of a disc herniation, disc bulge, disc tear, or stenosis or narrowing of where the nerves are traveling. So we have to wonder why. Why are they having this pain that's going down the leg? Now, sometimes it could be that the nerve is being irritated in other areas, right? The sciatic nerve could be irritated across the buttock, either at the piriformis muscle or more frequently at things like the obturator internus muscle or the quadratus femoris muscle with a posterior hip impingement. The nerve could be irritated further down, all the way down at the knee if we're just having symptoms down the leg, right? So there's a lot of different things that can cause radiating symptoms. Even irritation to the muscles. The muscles can actually, like muscles of the buttock and things along those lines, can actually refer pain down the legs. But when those aren't going on, and it seems like the nerves are still being irritated from the low back, but we don't see anything major going on, we have to ask the question, why, right? Now, we've talked in the past that disc bulges, number one, don't necessarily equal pain, but also there are situations where disc bulges can go away on their own with things like physical therapy, exercise, appropriate manual therapy, and sometimes injection treatments can cause disc bulges to go away. So disc bulges and even herniations can go away spontaneously, but sometimes they've already done their damage, so to speak, not necessarily damaging the nerves, but causing some level of irritation to the nerves. Even after the disc bulge has gone away for all intents and purposes, the after effects of nerve irritation can still linger on. We've talked about nerve irritation causing three primary types of symptoms. Number one is pain, and typically that's pain going down the leg or sciatica. Number two, numbness or tingling, right? Your leg's falling asleep, or there's areas in your leg that you can't actually feel. And number three is weakness. So a very important part of my physical examination when I test somebody that has what seems like sciatica or nerve irritation is I test the muscles throughout their leg to see if there's signs that the nerves could be irritated. Very commonly, we can see patterns of weakness that correspond with nerve irritation at specific areas of the low back. But when we look at the MRI, there's no disc bulge there, right? So what's going on? There's sometimes another hint that there could be something going on, and that is your multifidus muscles. So the paraspinal muscles I mentioned already are these muscles back here, right? These are the muscles that are actually in some groups. These muscles actually can are in charge of providing stability of the spine. And the bigger muscles here actually are, travel across multiple different spinal levels, and get their nerve signals, get their electricity from multiple different levels. But these smaller muscles, called the multifidus muscles or multifidi, and these tiny, tiny little guys that are across here called the rotatories, or I don't know how to pronounce them, but something along those lines. These little guys get their nerve innervation or their electricity from either that exact level or just a level above, level below. The nerves are the electrical wiring that go to our muscles, which are our appliances. So if the nerves are not sending the appropriate signals, then the muscles do not work properly and eventually start to die back and eventually get replaced by fat. So when we look at these, a lot of these muscles that we see here are all black or dark. And there's little white lines that we see kind of going throughout there. Those little white lines are fat that follow alongside these muscles. It's very common for these little strands of fat to follow alongside things like nerves. The nerves actually have fat protecting them, and as they travel through these muscles, so these little lines that we see for all intents and purposes are completely normal. And some people describe this, I'm a vegetarian, but I'll still describe it this way, as looking like some steak, right? Some marbled steak for all intents and purposes, and that marbling actually does worsen over time as we get older. So here's an example of this marbling actually getting worse a little bit as we are getting older here. So you can see that the white is starting to increase a little bit throughout the multifidus muscles first, and gradually over time it'll increase throughout other muscles as well. And it's typical, it's normal, it's common for us to see a little bit of that muscle atrophy or muscle starting to reduce in size and get replaced by fat as we get older. And typically that starts with the multifidus muscles. Again, typically that starts down at L5, S1, and gradually goes up higher as we get older. But we should theoretically see that white stuff increasing gradually, symmetrically, right? We should see that that muscle atrophy or dying back is actually occurring relatively symmetrically. So as those muscles start to get replaced by fat, we see that the increase in white happens pretty equally on both sides. So again, that could be a normal thing. Now, what I don't like is when I see something like that occurring in someone that's relatively young. If someone that's 21 years old and for all intents and purposes otherwise fit comes to me with some increased multifidus atrophy, well, then I have to wonder why. Why are those multifidus muscles not firing properly? And why is that dying back? Why is that muscle dying back? It could be simple things like deconditioning if we're not moving our bodies appropriately. Or it could be something a little bit more insidious, like a little bit of nerve irritation, or those muscles are guarding or not firing properly because something is going on in the low back that's causing those muscles to not fire. But the real thing that we need to look out for, and this comes from any age population, is ultimately if we see that multifidus atrophy, and if that atrophy is actually substantially worse on one side compared to the other. So again, here's an example of the same patient at a lower down level, and you can see that on one side here, when you look at these muscles, there's a little bit of white inside them, but there's a lot of black. On this side, however, there's a vast difference that you can appreciate with the multifidus muscles having significant atrophy on that side. Significant atrophy on that side. And that is a sign of something going on asymmetrically. Asymmetrically. There's more muscle atrophy on one side compared to the other. And that makes us think, all right, what is it exactly that's going on? There's a few different things that can cause this. Number one is if the nerves are irritated on that side, and therefore those muscles are dying back. They're not getting the appropriate signal, the appropriate electricity through the electrical wiring, the nerves, to those muscles, so those muscles are dying back. That could be a subtle sign. If this same patient, remember this is the left side, this is the right side, so if this same patient came to me and was like, hey doc, I'm having significant pain down my left leg, and I looked at them and the distribution of their pain was similar to the distribution of the same nerves that are exiting at this level, right? The same nerves that are traveling past this level or down across this disc bulge, and then it would all kind of, the puzzle comes together, right? It all makes sense because this is what's going on. Now, what if this patient told me, hey doc, I'm actually having pain on the right side. I'm having pain on the right side. Well, then maybe this multifidus atrophy is not the thing that's corresponding to the side of the pain, but maybe these muscles are working overboard, and therefore they're getting fatigued and therefore dying back, maybe, to take pressure off of something else on the right side. So for example, there's this disc tear that we see in this patient here on the right side, this white signal inside the disc that is indicative of a disc tear. Go to my prior videos on MRIs to hear about the discs and see what that looks like. But maybe the muscles on this side are rip-roaring tight and angry because they're trying to take pressure off of this disc tear. Right? If anyone has had pain associated with the disc tear, when their back goes out, oftentimes they complain that they're kind of crooked and they can't get out of that position. Well, that's because those muscles are freaking out to try to take pressure off of that disc. So these are all hints. There's all these things that are jumping out at us if we actually take a look at this imaging. Now, the final thing that can cause this atrophy asymmetrically on that side is, let's say somebody had back pain only, not pain going down the leg, but back pain only, and they'd seen pain physicians and they were told that it was coming from their facet joint right here, that this facet joint was angry and that's what was causing pain. So one of the traditional treatments for facet-related pain when it comes to traditional pain management techniques is what's called radiofrequency ablation. Radiofrequency ablation is basically burning or deactivating the little tiny nerves that go to these facet joints. And you do first a test called a medial branch block to decrease the sensation and see how much of the pain gets relieved. And if that improves, then you can then follow through with an injection technique where a modified needle, the tip of it actually gets really hot and it burns these nerves. Now what happens is the nerves get burned or deactivated, and those nerves eventually grow back over the course of 6 months or so. And in the meantime, since those little tiny nerves that go to the facet joints are deactivated, you no longer feel the pain coming from the facet joints. So it's great in theory, right? Just cut off the pain signals and you have less pain. But some theorize that those little tiny little nerves go to those facet joints, but also go to the multifidus muscles at that level. So if you do this radiofrequency ablation once and it lasts X amount of months, so you do it again and it lasts X amount of months, and you do it again and it lasts X amount of months, so each of those times we're decreasing the nerve signal to those multifidus muscles. Now this has been strongly debated, but some theorize that that can actually help deactivate these small little muscles and cause multifidus atrophy. Now I've seen the literature, and the literature is mixed on if radiofrequency ablation actually does cause multifidus atrophy or not. But this particular patient is a patient that had radiofrequency ablation on their left side only a few times in a row and ended up with this multifidus atrophy. So this is a pure example of how this can occur. And then now with this multifidus atrophy, since they had some more instability there, since those small stabilizer muscles were no longer providing stability, they ended up having more issues in the low back, including eventually getting this tear. So it's really important to recognize that we have to be careful about the type of treatments that we get, and we have to be careful about the potential repercussions of them. Sometimes radiofrequency ablation for facet joints, for example, is absolutely appropriate. If you're 85 years old, and as I mentioned, your multifidus muscles normally atrophy or go away as we get older. So if you're 85 years old and you have bad facet joint arthritis, and those multifidus muscles of yours are already atrophied, then radiofrequency ablation may be perfectly appropriate as a solution. But if you're 20, 30, 40, 50, 60, and even active, and don't have multifidus atrophy already, why add fuel to the fire, right? But when the multifidus atrophy is significant, is absolutely severe, then sometimes radiologists will comment on it. But if there's subtle multifidus atrophy, then a radiologist may or may not comment on that. So therefore, it's really, really important that the physician that you go to for your care is looking at the images themselves. And again, when we talk about orthobiologic treatments, things like PRP, stem cells, etc., we really want to look at the whole functional spinal unit. And if we do have asymmetric multifidus atrophy or even symmetric multifidus atrophy in younger patients, we need to be addressing those as well. There was one paper, not the greatest of papers, but one research paper out of Egypt that looked at repetitive injections of PRP into the multifidus muscles and actually showed a little bit of reversal of the atrophy. I have not actually seen that occur in my practice when I've done repetitive injections of PRP into the multifidus muscles, but I have seen patients improve in their stability and their strength in their spine, subjectively and objectively seen improvement of strength in the muscles down the legs. With treatment of the whole functional spinal unit, we can oftentimes get great results. So, hope that all made sense. The point of today's talk was really to talk about two important things that not all radiologists will talk about when they report on your low back MRI. All the more important for your physician to look at the images themselves, especially if we're doing orthobiologic procedures, but really anybody that's treating your spine should have their eyes on that. These injections, furthermore, I have to mention, these injections should absolutely be done with image guidance, because I've seen patients, or I've seen other practitioners do blind injections and claim that they are injecting the facet joints, various different ligaments, even some deeper ligaments that quite frankly need image guidance in order to get to safely. I have seen some scam artists online injecting into the epidural space and the discs without any image guidance. That is not only foolish, fake most likely, inaccurate, and absolutely dangerous, because we got to understand that injecting into these areas is not something to take lightly. There are risks such as nerve damage, spinal taps, spinal headaches, dural puncture issues, significant things like infections in the spine that could be absolutely terrifying. So we should not be taking these lightly. We should be doing these with image guidance, with safety in mind, number one, first and foremost. So I'm just going to go to the comments real quick. Varun, thank you for coming in and commenting. The physicians need to be capable of reading MRIs rather than simply reading the report. That is so true. He said, may I ask what kind of injections you'd use for treating ligamentum flavum hypertrophy? So first and foremost, just backtracking, I don't call it hypertrophy, I call it kinking or redundancy, because I think that oftentimes, now sometimes it could actually be thickening of the ligaments, but oftentimes it's because those ligaments are looser. So I use either prolotherapy or PRP, different types of PRP, to treat directly at the ligamentum flavum, as well as the interspinous, supraspinous ligaments, the thoracodorsal fascia, all of those things to tighten that whole chain. Debbie said, so cool. I agree. Norma said, would fascia stretch therapy help, especially after PRP or stem cell injections? Great question, Norma Jean. Fascia stretch therapy can be absolutely beneficial, but we've got to make sure that we're doing it in an appropriate way, number one, and number two, that we're not doing it when the fascia is already stretched too much. right? Because in some situations, the fascia may be tight on one side, loose on the other, and the appropriate manual therapist would be able to, loosen where it's tight and not loosen where it's already loose, right? That's where the biologics come into play, because the biologics help with tightening, whereas the manual therapy helps with loosening. Varun asks again, what disc level is this, L4-5? With this last one, I don't know when you commented or so which view that we were looking at, but this one I believe was at the L4-5 level. Mike says, yep, it's freaky. Absolutely. Ligament laxity is freaky. Sometimes it is completely normal. When we're kids, it actually helps us prevent injuries, right? Because we quite literally bounce back. But as we get older, there could be issues that are associated with it. Debbie asked, what's fascia? I'll do another talk entirely on fascia, but I think fascia is a very, very important thing. It's technically the biggest organ in our body. We used to think that the skin was our biggest organ, but the fascia actually is something that penetrates in and around all muscles, all bones. It's the connective tissue that connects us all. Very, very important concept called tensegrity that I think we'll touch base on a future video, so stay tuned. And Carol said, can enough platelets be gotten to treat a large enough area as the lower back with the pelvis and SI joints for PRP? When we get platelets, when we use these kits, a lot of people use kits for PRP injections, and sometimes we're only able to get small volumes of platelet-rich plasma with using kits. We can use a combination of different kits or manual processing. There's different ways for us to get enough volume, but it's not only the volume, but it's also the platelet count, the concentration that ends up being so important. Mike said, I meant the back injections, not imaging, is freaky. Yeah, that's even freakier, man. Ligament looseness can certainly be freaky, but injections without image guidance into the spine, definitely freaky. Now, some things like some of those superficial ligaments you could do without image guidance, but once you start saying that you're going to be getting out of the facet joints and things like, some people do things like rib joints and all this kind of stuff, that stuff's scary. But I hope everyone enjoyed this. If you like this video, please like it, share it with your friends, share it with your enemies. I think it's important to know how to look at your own MRI and how to, quite frankly, ask the right questions of your physician and make sure that they're looking at your images before doing treatment. I hope that you understand that that's the take-home point from this lecture. Hope you enjoyed it. We're going to be shifting gears away from the spine and going to some other topics, most likely starting next week or the week after. If you have specific things that you want me to talk about, drop me a comment, drop me a direct message, or you can email us at info@fxregencenter.com. Hope you guys have a great Friday, a great weekend, and I'll see you next week.